Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 4 of the cardiology chapter. We're going to start by talking about heart sounds and murmurs. Heart sounds are generated by the closing of valves. Understanding when valves normally open and close during the cardiac cycle will make it easy to understand how abnormal valve or heart function will cause abnormal heart sounds. There's a figure in the book that you can refer to when various valves are mentioned to understand where they are heard best. A mnemonic commonly used to remember where to auscultate for each valve is apartment M, or APT-M, as in Mary, for aortic, pulmonic, tricuspid, and mitral. S1. This is a sound made normally by the closure of the tricuspid and mitral valves. This sound marks the end of diastole because filling of the ventricles is complete. These two events occur nearly simultaneously, so there is never any splitting of this sound. S2. This is a sound made normally by closure of the pulmonic and aortic valves, referred to as P2 and A2 respectively. This sound marks the end of systole because ejection of blood from the ventricle has now been completed. During inspiration, intrathoracic pressure becomes more negative, sucking more blood back into the right atrium from the vena cava, increasing venous return. This increases right ventricular preload, leading to a larger right ventricular stroke volume, prolonging the duration in which the pulmonic valve is open. It needs more time to eject all that extra blood. This moves P2 after A2 and causes the S2 sound to be split, termed physiologic splitting, a completely normal entity. On expiration, this does not occur, and P2 and A2 occur at the same time, causing the S2 sound to not be split. There are some examples of when splitting can be pathologic. Fixed splitting is described when splitting occurs on both inspiration and expiration. This occurs with an atrial septal defect because there is a hole between the two atria. Because there is always a left to right shunt present, because left atrial pressures are higher than right atrial pressures, the right ventricle always has increased preload, and the pulmonic valve will always close after the aortic valve. Wide splitting. Described when the P2-A2 split is longer than usual, seen with anything that causes a delay in right ventricular emptying. With pulmonic stenosis, the valve is narrowed, and therefore it takes the blood longer to fully eject, leading to a delay in valve closure. In right bundle branch block, the fast His-Purkinje system to the right ventricle is blocked, and right ventricular contraction is delayed, causing the pulmonic valve to close after the aortic valve because the left ventricle will contract and finish ejecting blood first. Paradoxical splitting. This is described when the aortic valve paradoxically closes after the pulmonic valve, seen with anything that causes a delay in left ventricular emptying. This causes the split to paradoxically occur during expiration rather than inspiration. This is because the pulmonic valve is closing earlier than the aortic valve owing to pathology, but during inspiration, the increased volume moving through the pulmonic valve allows the valves to open for the same amount of time. As you may have guessed, aortic stenosis and left bundle branch block can cause this, for the same reason described with wide splitting, just now affecting the left ventricle. Normally, there are no other sounds other than S1 and S2 during the cardiac cycle. However, there can be extra sounds called S3 and S4 sounds. S3. Although this can be a normal finding in children, it is always abnormal in adults and usually signifies volume overload. When the tricuspid valve and mitral valve open during diastole, the extra volume rushes into the ventricle, tensing the chordae tendineae, the tendons that tether the valve to the heart of the affected valve, depending on which side of the heart is overloaded with volume, causing the extra sound. The sound is heard during the rapid ventricular filling phase in early diastole and is therefore positioned after the S2 sound. S4. At the very end of diastole, the atria contract, called the atrial kick, trying to squeeze in the last bit of blood before the mitral and tricuspid valves close, the S1 sound. If the ventricle is stiff and non-compliant, such as from hypertrophy, from hypertension, there will be no room for the extra blood, and the S4 sound will be generated. Because the atrial kick occurs just before the end of diastole and closure of the AV valves, this sound is heard just before the S1 sound. Blood flow through the heart is normally laminar and silent. When there is turbulent blood flow through the heart, a murmur is heard. Turbulent flow through a narrowed artery is instead called a bruit. Understanding the cardiac cycle and when valves should be open or closed makes understanding murmurs more easy. Stenosis is a problem with opening a valve because it has been narrowed, whereas regurgitation or insufficiency is a problem with keeping a valve closed. During systole, the aortic and pulmonic valves should open to allow for ejection of blood from the ventricles, and therefore the murmur of aortic or pulmonic stenosis will be heard during systole. Because the tricuspid and mitral valves should be closed, the murmur of tricuspid or mitral regurgitation will also be heard during systole. Aortic or pulmonic stenosis. The murmur is described as crescendo, decrescendo, or diamond-shaped, because as the contraction of the heart progresses, the pressure builds up and drops again, leading to a murmur that increases and then decreases in intensity. Individuals with aortic stenosis will often complain of chest pain because of increased myocardial oxygen demand from the increased afterload. They may also experience exertional syncope because the demands for increased cardiac output during exercise cannot be met with the high resistance through the aortic valve, and will experience syncope owing to cerebral hypoperfusion. Classically, on physical exam, these patients will have pulsus parvus et tardus, which is Latin for a weak, parvus, and late, tardus, pulse. Predisposing factors to aortic stenosis include congenital bicuspid aortic valves, where there are two cusps instead of three, and rheumatic heart disease causing damage to the aortic valve. Mitral or tricuspid regurgitation. The murmur is described as holosystolic or pansystolic because it occurs at the same intensity for the duration of systole. This is because the left and right atria have low pressure and can accept blood even at low pressures if the valve is incompetent. Mitral valve prolapse. The most frequent valvular lesion, where an abnormally thickened valve prolapses into the left atrium during systole. The sudden tensing of the chordae tendineae that stops the movement of the valve causes a click to be heard, and an end-systolic murmur is present if there is regurgitant flow. This is most often a benign lesion. It is associated with connective tissue diseases such as Marfan syndrome and Ehlers-Danlos syndrome. Ventricular septal defect. If there is a passage between the left and right ventricles, during asystole, the left ventricle, which has higher pressures, will eject blood into the right ventricle, leading to a left to right shunt. This leads to a holosystolic murmur, similar to that of mitral regurgitation. It is classically described as harsh sounding, whereas regurgitant murmurs are high-pitched. During diastole, the tricuspid and mitral valves should be open to allow for ventricular filling through the atria, and therefore murmurs of tricuspid or mitral stenosis will be heard during diastole. Conversely, the aortic and pulmonic valves should be closed to prevent backward flow of blood from the arteries into the ventricles, and therefore the murmurs of aortic or pulmonic regurgitation will be heard during diastole. In contrast to systolic murmurs, which can be benign, diastolic murmurs are always pathologic. Mitral or tricuspid stenosis. The murmur is described as beginning with an opening snap when the stenotic valve finally opens, followed by a turbulent, rumbling murmur. Most commonly, this is caused by rheumatic fever, which most often affects the mitral valve. Aortic or pulmonic regurgitation. The murmur is described as early decrescendo because after the ventricles eject the blood, the valves should shut. Failure to do so causes blood to crash back into the ventricle during diastole, leading to the murmur. Because in aortic regurgitation, the blood crashes back into the left ventricle instead of staying in the systemic circulation, there is a wide pulse pressure from decreased diastolic blood pressure. This drop in diastolic blood pressure leads to many clinical signs, including a large volume pulse that collapses in diastole, termed a Corrigan water hammer pulse. De Musset sign, in which the head bobs with the heartbeat, and Quincke sign, in which the capillary bed in the nail can be seen to be pulsating from the wider pulse pressure. Lastly, the murmur of a patent ductus arteriosus, or PDA, is a continuous murmur. It's present in systole and diastole, and it's described as machine-like. See Chapter 4 for a detailed description, but briefly, the ductus arteriosus is normally open when the fetus is in utero to act as a bypass tract from the pulmonary artery to the aorta because the lungs did not need significant blood flow, because a fetus can't breathe in utero. After birth, the increased oxygen tension in the lungs, because the baby now needs to breathe, causes constriction of the ductus arteriosus and eventually fibrosis, becoming the ligamentum arteriosum. Although a postnatal PDA is not normal, it may be beneficial to the baby if there are other congenital heart disease lesions present. Vasodilating prostaglandins keep this open, and therefore medications that block prostaglandin synthesis, such as indomethacin, will promote closure, whereas given prostaglandin E analogs, such as misoprostol, will help keep it open. Performing maneuvers that change afterload or preload can change the intensity or characteristic of certain murmurs and may allow the clinician to diagnose valvular disease from physical exam alone. For instance, right-sided lesions get louder with inspiration due to increased right ventricular preload. Increasing afterload, such as clenching a fist, increases intensity of aortic regurgitation, mitral regurgitation, and ventricular septal defect murmurs. Decreasing preload, such as with a Valsalva, will cause many murmurs to decrease in intensity and the mitral valve prolapse click to occur earlier, while increasing preload, such as with squatting, will cause increased intensity of aortic stenosis murmur and mitral valve prolapse click to occur later. So let's now have a brief summary of murmurs. Although it's good to know about all the murmurs, left-sided lesions are much more likely to be tested on step 1 and also are more relevant clinically. Furthermore, right-sided murmurs will usually have a question stem that hints at intravenous drug use, tricuspid regurgitation. Mitral stenosis will often have a question stem that hints at rheumatic fever. Aortic regurgitation will usually be your diastolic murmur without other clues. The main goal will then be distinguishing the two left-sided systolic murmurs, aortic stenosis, which is crescendo-decrescendo and radiates to the carotids, and mitral regurgitation, which is holosystolic and radiates to the axilla. That's the end of this section. In the next section, we'll be discussing pressure in the cardiovascular system.